be about pleural effusion. So we'll see how to approach a case of pleural effusion. Okay, in today's class, let's learn that. How we'll be dealing with it is, as usual, introduction, history, examination, what are the investigations available, how we approach the case, in the end summary, and throughout we shall have case scenario. And case scenario, what I've tried to do was just now going through the YouTube videos which we have and saw that no case presentation has been made on pleural effusion as such. So we will take up a model case and expecting all to participate in it. So you guys, like how in your clinics, how you take up your history, you keep asking the questions and I'll answer for it. So let's proceed that way. I think so we can make it more interesting also. Everything is fine now. We can start. Audio is clear. Screen is visible. Yeah. Okay. So let's proceed that way. Okay. YouTube also, everything is fine. So let's start. So firstly, we'll start with introduction. And what is pleural effusion? It's nothing but accumulation of the fluid. Accumulation of the fluid where in the pleural cavity. So accumulation of fluid in the pleural cavity is called as pleural effusion. And what is this pleural cavity made of? Pleural cavity, it has on one side, it has the visceral pleura, and on the other side there is the parietal pleura. Okay, and how is this fluid formed is, see, we see over here there is alveoli. There is alveoli on one side. After alveoli, there is some amount of interstitium and loose areolar connective tissue. And over here there is the visceral pleura. Visceral pleura is present. And on the other side, there is parietal pleura. And over here in between is the space. Okay, parietal pleura are drained by lymphatics. Over here, there are pulmonary capillaries present. These pulmonary capillaries, from here, the blood drains out. Why this happens is, there is negative pressure. No? This is the intrapleural pressure, which we have learned. Intrapleural pressure, it's usually negative. This is very much necessary, one, for the lungs to recoil and the lungs to expand. This negative intrapleural pressure is necessary. And because of the same negative intrapleural pressure, the blood seeps out. And the blood that comes over here, the filtered fluid that comes over here makes up the pleural fluid. And whatever has come will be drained through the lymphatics, which are present in the parietal pleura. Again, over here, there will be loose connective tissues. Over here, there are the stomas, which are present in the parietal pleura, and lymphatics picks up the fluid. So this is how, this is the basic layout. Coming to pleural fluid. And so why is it necessary? What is the function? One, yeah, since there will be fluid as compared to the lungs directly pressing over the chest wall. If there is fluid, it allows greater range of movement. So extensive movement with respect to the chest wall for the lungs. So lungs can expand and relax more extensively due to the presence of this pleural fluid. So it reduces the friction. Next is mechanical support. The visceral pleura which is there gives mechanical support to the lung. One more is very important is it provides route for the edema of the lung to escape. So whatever fluid is collected in the interstitium or whatever fluid comes out of the pulmonary vessels, pulmonary capillaries which we see over here, it can be drained out through the lymphatics because of the negative pressure that is created. So that is why pleura is necessary. The pleural space and pleural fluid is necessary. So as we see over here, a sustained rate of more than 30 times the normal fluid is required to be secreted for pleural effusion to take place. Okay, so that is the capacity of the lymphatics drainage. Okay, so that strong the system is. Next, what are the characteristics? Characteristics, one, it is clear fluid. So on appearance, it's clear in appearance. Usually around 10 to 20 ml of fluid will be present. So by body weight, 0.1 to 0.2 ml per kg. Then upper limit, we can take it to be around 20 ml. So it's a low protein fluid, like around 1 to 1.5 grams per deciliter will be present. Glucose will be same as the serum because it is the same thing, blood which has filtered through the pulmonary capillaries into the pleural space. So the glucose will be same, but proteins cannot filter out because of the size. The capillary endothelium will not let it filter out. Next, pH is slightly on the higher side, slightly alkaline. So totally around 12 ml per day is secreted. Cells, there will be around 1000 to 1500 cells per millimeter cube, and LDH will be less than 50% of the plasma. These are the normal characteristics of the pleural fluid. Next, let's look into some amount of anatomy. Anatomy, we just now saw there is visceral pleura on one side, there is parietal pleura on one side, and separating these two is a real space, which is nothing but the pleural cavity, which is filled by pleural fluid. And these two, visceral and parietal pleura, they meet each other at the hilum through the ligament, pulmonary ligament, if I'm not wrong. Next is the embryology. So it starts to develop at 3 weeks of age. So it develops along with other peritoneal spaces like pleural, pericardial, peritoneal spaces. It develops along with them. It starts to develop, as we all know, very important point, it is mesodermal in origin, and by 9 weeks of age it develops. Why 9 weeks? Because the lungs start to develop, the buds which come out picture outline. So first we see the alveoli. Here is the alveoli, and this is the interstitium. Okay. Next is the loose areolar connective tissue. And these are the pulmonary capillaries, some amount of pulmonary capillaries. So either the fluid that is accumulated in the interstitium or fluid that drains out through the pulmonary capillaries, okay, they come out into the pleural space. How? What is this pleural visceral pleura lined by? It's lined by mesothelial cells. It's lined by these mesothelial cells, and the space between these mesothelial cells allow the pleural fluid to drain. Once it comes into the pleural space, why it drains out? Because of the negative pressure, as already discussed. Okay. Over here, what happens? This side is parietal pleura. Again, parietal pleura is lined by the mesothelial cells. See what you see over here are mesothelial cells, and in between the mesothelial cells, there are large stomas for the lymphatics to drain. So whatever fluid, excessive fluid that comes over here will be drained into the lymphatics. Okay. Again, there is loose areolar connective tissue over here as well. Okay. So this is the layout. See, these are the stomas. These are the large stomas, the space which drains into lymphatics. These are the large stomas. This is the mesothelial cell. Between the mesothelial cell is a large stoma, electron microscopy, which you see. So coming to the blood supply, can you guys answer whether it is systemic or pulmonary circulation that supplies the visceral and parietal pleura? Very important question. Okay, all of you are telling systemic. Very good. Pulmonary fluid, pleura is supplied by systemic. How is it drained? Drainage of the fluid, what does it involve? Systemic or the pulmonary circulation? Meaning the venous drainage. Is supplied by mainly the bronchial arteries, so it is systemic in nature. But the visceral pleura is drained by pulmonary veins. It's drained by pulmonary veins. So the drainage is both systemic and pulmonary, but the supply is only systemic. So very important. Next, anyone knows what this is? Campmeyer foci. What is this? Have you guys heard of this? Have you guys heard of Campmeyer foci? No, Rishabh, it is not that. It is not the TB foci. It is something to do with pleura only. So this is involved in the local defense. So beneath the parietal pleura, there is loose areolar connective tissue. No, so there will be collection of lymphatic foci. Lymphatic foci collection will be there. Okay, this lymphatic foci collection is called as Campmeyer foci. Okay, it is involved in local defense. Okay, so very important, Campmeyer foci. It's not yet been asked, but can be asked. Next, nerve supply is simple. Yeah, but till now we were of the thought that the parietal pleura is supplied by the sensory nerves and that is responsible for pain. This I put in to know that recently even the visceral pleura as well as is supplied by some amount of sensory nerve fibers. So both the pathology for the pathophysiology of pain, both the parietal irritation of parietal as well as visceral pleura can cause the pain. So that is why I put costal and peripheral diaphragmatic pleura. It is supplied by intercostal nerves. So the pain over here, where will it be referred to? It will be referred to the adjacent chest wall. Next comes the central diaphragmatic pleura, again supplied by phrenic nerves, and it is, since it is phrenic nerves, ipsilateral shoulder pain we get. Next is visceral pleura is also supplied by some amount of sensory nerve fibers. So pain and dyspnea it can cause, okay, irritation of the visceral pleura. Very important point, okay. This is a very important point. This is a recent update. Next, let's look into how this pleural effusion is formed. Now we saw, till now we were seeing the normal pleura and pleural fluid. How is it formed? Because of the negative pleural pressure, and it is drained by the lymphatic because it has a huge capacity of draining 30 times the normal fluid. So when the secretion is above the 30 times, then pleural effusion is said to be present. So we can just take it by nature that if pleural effusion is present, it has to be pathological almost all the times, because for the effusion to be present, there should be 30 times more than the normal amount of secretion. No? So for that sake, we take it that way. So it can be, again, as we discussed in edema chapter, it can be transudative or exudative. Transudative is what? Protein poor fluid. Exudative is protein rich fluid. How is exudative fluid formed? It is formed by increased filtration through injured capillary beds. So the normal capillary beds which we saw over there couldn't filter out the proteins. That's why the pleural fluid normal characteristics when we saw, they contain very less amount of protein. So through, if it is injured, if these capillary beds are injured, then the proteins can seep through. No? So that's why exudative pleural effusion characteristic is protein rich fluid. So pleural fluid protein will be high. Next is protein poor fluid, transudative. Why does this take place? One, because there can be increased filtration of the fluid across the intact epithelium. So how does this take place? Either it can be because of increased hydrostatic pressure. Again, we read about this when we were doing edema. This can be because of congestive heart failure, or it can be because of decreased osmotic pressure. This will be in case of nephrotic syndrome or anything that can cause hypoalbuminemia, malnutrition, all those things can cause. Next, coming to entry of another liquid. If some other liquid that is of transudative nature enters into the pleura, then even that can cause. So what can that be? That is what we see in ascites in case of hepatic hydrothorax, or there is something called as urinothorax, wherein through the retroperitoneum urine collection, again through the diaphragm it will come and collect, or you can see due to accumulation of CSF, so abnormal connection taking place from the ventricle to the pleura, it can result in accumulation of CSF. Even in that case, we'll get transudative fluid. Okay, so next, if the cause is lymphatic obstruction, then we can expect both exudative and transudative fluid. Okay, exudative and transudative, because anything can take place now. So both exudative and transudative fluid. So next, let's look into what are the causes. So basically two different types. Just now we saw with that there were transudative and exudative. So now what is important for us is exudative, there are n number of causes. So they might not concentrate on that, but what they will concentrate on is transudative. And even in transudative, three causes are very common. All of us remember. One is congestive cardiac failure. Second one is due to ascites. Third one because of nephrotic syndrome. Okay, this all of us tend to remember. So where do we tend to make mistake is other one. Please try to remember this, because we'll invariably end up getting confused. So very important are the causes of transudative. These three we'll anyways remember, so they might not end up asking. The other causes are important. One is pericardial disease. Pericardial disease causing constrictive pericarditis. That is important. Next, continuous ambulatory peritoneal dialysis. If the patient is on CAPD, then obviously the fluid which is over there will seep through the diaphragm and get collected in pleura. So that is fine. Next, urinothorax we just now discussed. Next is mixed edema. Mixed edema, a very important cause. Don't forget. Okay, this mixed edema, it can be, usually it will come with pericardial effusion also. So we can, if there is mixed edema causing pleural effusion, look for pericardial effusion also. Next, central venous obstruction. Central venous obstruction like superior vena cava obstruction or hemiazygous vein thrombosis, all those things can cause. One more, subarachnoid pleural fistula, we just discussed. In this, CSF will land in how secondary to trauma, or when we are doing a VP shunting, all those things, or trauma to spinal cord, all those things can cause CSF in the pleura. Next, veno-occlusive disease. They might not ask veno-occlusive disease, but they'll ask Budd-Chiari syndrome. Budd-Chiari. Classic example is Budd-Chiari syndrome. Next, bone marrow transplantation and iatrogenic. By iatrogenic, they mean that once you put CVP line, the fluid might escape if you cause damage to the pleura. So important causes 1, 2, 3. Apart from this, what is important is urinothorax, mixed edema, central venous occlusion, Budd-Chiari syndrome, and very important, constrictive pericarditis. Don't forget constrictive pericarditis. We might end up marking exudative because pericarditis means inflammation. So we will end up marking exudative. But no, constrictive pericarditis also causes transudative pleural effusion. So please remember the causes for transudative pleural effusion. Exudative, there are n number of causes. So one will be neoplastic disease. Next can be because of infection, because of pneumonia, or because of TB. Those two being the most common, or other any fungal, parasitic, viral, all those infections as well can cause effusion. Next, pulmonary embolism. Next one is GI disease like esophageal rupture, so perforation of the esophagus, or any intra-abdominal abscess, pancreatic disease, all those things. Next, we can have what? Inflammatory diseases, autoimmune diseases. This will end up causing pleuritis. Secondary to pleuritis, we'll get pleural effusion. So two most common is rheumatoid arthritis and SLE. Next, post-cardiac injury syndrome. What is the other name for post-cardiac injury syndrome? Anyone? Other name for post-cardiac injury syndrome? Yes, very good. Dressler syndrome. Nothing but Dressler syndrome. Next, again, post-CABP. Why CABP? Because when you're doing surgery for coronary artery bypass surgery, you will end up irritating the pleura, no? That's why there will be fluid collection. Next, again, Fontaine procedure. Very important is asbestos exposure. Asbestos exposure, what happens is even the benign cause of asbestos exposure, benign asbestos disease also can result in pleural effusion. It might be asymptomatic as well, but what is important is to rule out mesothelioma in this case. Next, sarcoidosis, Meeks syndrome, OHS, all these things, few rare diseases. Again, next, what is important to us is drug-induced pleural disease. So again, very important to remember all the drugs. From entrance exam point of view, it has been asked many number of times. So all these drugs, please do remember. So one is nitrofurantine, second is dantrolene, third methysergide, bromocriptine, procarbazine, amiodarone, and dasatinib. So again, once again, I repeat because it's very important for us to remember. Since it's been asked many times in our entrance exam: nitrofurantine, dantrolene, methysergide, bromocriptine, procarbazine, amiodarone, and dasatinib. Okay. So, and there can be hemothorax and chylothorax. Okay. So this is a question for you guys. Causes of both exudative and transudative. Exudative and transudative. No. Yeah, but we are very good. It is pulmonary infarction. Pulmonary infarction. In pulmonary infarction, this is classical. We can get both exudative and transudative. Okay. Cause of mechanism of pleural effusion, Meeks syndrome. Meeks syndrome, it can be because of certain inflammatory mediators which might go and irritate the pleura. That's what I can think of. Even I'm not much aware of the mechanism of in Meeks syndrome. Okay, I'll look into it. Mostly it is that because there will be, since there is malignancy, some amount of or it can be because of there will be ovarian tumor. Ovarian tumor is leading to ascites anyways. That ascites fluid will seep into the pleura. That's why we'll have right-sided pleural effusion. No, so it is mostly that. Secondary to ascites, we are having one of the cause it will be. Next, so history. So now let's look into our case scenario. Okay, so case scenario, how we are dealing is like your normal clinics. This will be like your normal clinics. Okay, first, then it should be transitive. But you don't know what kind of fluid is collected in the peritoneum. No, it is because secondary to the tumor that is collected in the peritoneum, the fluid that has been collected. So when the nature of peritoneal fluid itself might be different, might be exudative. So first is the case scenario. Case scenario, okay. Now I'll tell the chief complaints. It's a kid, okay? Kid presenting with worsening dyspnea, cough, okay? Along with there'll be swelling of bilateral limbs. Swelling of bilateral limbs is there, and abdominal distension is there. Okay, you are directly jumping to diagnosis. That is one of the main mistake you'll do in your clinics also. So one thing is that in our clinics, we'll already know what the diagnosis is. So we will jump into diagnosis. That is not how we do. Okay, since it is, so we'll start with what? How we'll start? We'll start with age of the patient and we'll go forward. So age of the patient is, age of the kid is around 6 years, male. Okay, 6 years, male. This is the chief complaint. So we'll elaborate on HOPI. So how do we take our HOPI? We'll elaborate each thing. So first one, I like to mention the duration. No, so swelling of bilateral limbs came first. This has been present since 1 week. Okay, it was followed by this since 4 days, and these two have been present since 3 days. Okay, so this is how it is. So what do you like to ask? Very good. Onset, and if anyone want to volunteer, that is also fine. For history, one can volunteer. For examination, other can volunteer. Anyone want to? Can you guys raise your hands? Message. Like, you don't have to diagnose also. It is just how you take a case in your normal clinics. You guys ask me question, I'll reply to it. Okay. You guys will ask through chat. Anyone can. It can be more interesting if you guys volunteer. Okay, Rishabh. Rishabh, could you unmute?
Yes, sir.
Yeah. So next, how do we deal with this case? There is bilateral limb swelling.
So dyspnea is done, sir. I didn't listen to it. We'll start with the onset of the dyspnea.
Okay. So when you go in chronological order, which comes first? Basics of clinics.
Swelling bilaterals.
Yeah. So swelling, bilateral limb swelling. What would you like to ask in bilateral limb swelling?
Did it start from legs, or was it first observed in the face?
Okay, now since you asked, the patients are telling it was observed in the face. Bilateral eye puffiness was present on getting up early in the morning. After that, they have started to observe this also. So it is bilateral symmetrical swelling, not associated with pain. So you can rule out infection also. So what do you think it is? Anything else you want to ask?
Anasarca.
Okay, anasarca you think it is. So okay, fine. So you asked history for bilateral lower limb swelling, and then you'll ask history for abdominal distension, no?
Yes, sir.
So, okay, abdominal distension, what you'd like to ask? Again, onset and
Is there
duration,
a
how it progressed.
yes? And
Insidious
is
in
there
onset,
associated pain?
gradually progressive, not associated with pain, and generalized abdominal swelling is present. Okay.
Okay.
So next, and participants, you can also ask question through your chat box. Yes, Pujashri asked for reduced urine output. Reduced urine output, okay, as of now, it's not present, Pujashri. There's no reduced urine output. Okay. Okay, next, you'll ask for dyspnea, no?
Yes, sir.
So,
Onset.
how you'll ask for dyspnea?
Onset, progression.
Onset and progression. So, why you want to grade the dyspnea, correct, no?
Yes.
So, what grading will you use in our case?
NYHS.
NYHA. Why? Why do you think so?
This could be a cardiac cause also.
Cardiac cause also. But did you ask anything to confirm whether it's a cardiac cause?
Not yet, sir.
Not yet. No. So yeah, you'll ask for PND, orthopnea, all those things. So they were not present in this case.
Okay.
And abdominal tenderness was also not present. So you cannot think of some right-sided heart failure or something, because there is dyspnea, there is bilateral lower limb swelling, there is this thing. Yes, good, you ruled out cardiac cause. Now you take MMRC grading, correct? No.
Yes.
So how do you ask in MMRC grading for dyspnea?
Whether the patient is able to do routine activities. Is that breathlessness or doing routine activities, or an exertion like climbing stairs or walking 100 yards?
Good. So no. So be aware. Dyspnea means they'll ask what is the mechanism of dyspnea, how do you grade dyspnea, NYHA, MMRC, if there is anything else present like Sherwood-Jones. So be aware of it, okay? And how do you differentiate cardiac from respiratory cause? In this case, initially, like he could do all the activities like his counterpart kids. Now he's slowly started to develop dyspnea. Even while rest, he's feeling dyspnea now. Okay, even on rest, he's having dyspnea since the past 3 days. Okay, so you have, yeah, good. You have graded the dyspnea. Next, dyspnea is done. Next, you will come to cough.
Cough.
Yeah, cough. What would you like to ask?
Again, onset and associated with sputum.
Associated with sputum. Again, you can rule out infection also. Someone has asked for fever. So there's no history of fever. Sputum, very scant sputum was present. Next. Color of the sputum, it was normal, white in color. It was not associated. It was not foul smelling.
Any chest pain?
Okay, chest pain as such, no chest pain was there. Would you ask any relieving features for dyspnea? If you are suspecting a case of pleural effusion, would you ask for
positional variation, sir?
Positional variation, that is important. Yeah, on leaning on the right side, he feels better. On leaning on right side, he feels better. Okay, cough also. So cough, what all you'll ask as examiner, what all they'll ask type of coughs, expectoration, what are the type of expectoration, color, foul smelling or not, all those things they'll ask. So be aware of it. So those are the questions they can ask you. Okay, blood tinged or not? It was not blood tinged, Chaitanya. So next, what would you like to ask? You got all the positive history.
Yes, sir. Now regarding the nephrotic syndrome, like renal
so in
symptoms.
Your differential diagnosis, what you're keeping? Nephrotic syndrome first. Okay, renal involvement secondly to nephrotic syndrome. Okay, you can also keep CCF because all the things are coming towards CCF also, but you have ruled out. There is no orthopnea
PND and orthop
for left heart failure you're thinking of. Okay, but right heart failure symptoms are still present, but still there is no tender hepato, right upper quadrant pain. JVP on further examination, if you see, might not be raised. So in that case, you can rule out right heart failure, but it is a good differential diagnosis as of now. Correct, no?
Yes, sir.
Yeah. Okay. So next, in terms of nephrotic syndrome, you want to ask. What else you want to ask then?
Urine output, sir.
Urine output was fine.
Okay. Like hyperlipidemia symptoms.
Hyperlipidemia, what symptoms do you expect? Usually lab value you can measure, lipid profile you can measure. Yes, very good.
Frothy urine, sir.
Frothy urine was present. Frothy urine was present in this patient. Okay.
Okay.
So next, negative history, would you like to ask anything?
Blood in urine.
You ruled out CCF, one thing. Anything else you want to ask? Blood in urine, very good. There was no blood in urine. There was no decrease in urine output. There is no history of skin lesions or sore throat in this patient. Good. So drug history, will come to it later when we are doing treatment history. So these are the questions we have asked now. Any complications would you like to rule out, Rishabh?
Any thrombotic lesions?
Yes, thrombotic lesions, any infection, all those things rule out. What else? Any other complication you'll expect? Growth retardation, all those things you'll expect, no, in this child?
Yes, sir.
Yeah, okay. Failure to thrive, very good. Gain in weight, all those things you will ask. Spontaneous bacterial peritonitis, yeah. So good, you guys are aware of all those things. So no, as of now, no such complications are present in this child. Next, moving on to past history. Past history, what you like to ask?
History of any infections in past?
No, that is not present. So you're thinking in terms of nephrotic syndrome. So past similar episodes will you ask for?
Yes, sir, because it might have been a relapse.
Yeah, it might have been a relapse. Good. Kid was admitted a month back for this, not a month back, 2 months back for similar complaints. He was given steroids. Okay, we'll keep it as 6 months back. He was given steroids, and after that, patient totally recovered. There was no proteinuria noted, or 1+ proteinuria was noted on doing urine dipstick test. Okay, so drug history also only this much is significant.
Yes, sir.
Okay, anything else you would like to ask in history? Multiple infection to rule out cardiac cause. Good. We should know there's no history of such multiple infection in this patient. After past history, what do you go to?
Family histories.
Yeah, family history, nothing significant was present. Anything else you want to ask?
Drug history.
Personal history. Drug history told, no? Same thing. Steroids, but is right now not on steroids.
Okay, sir.
So next we'll go to what? Personal history. Personal histories, you can tell sleep was altered in this case. Diet was altered. So anything else? No habits as such. It is a kid. Bowel and bladder movements you should ask for. It was normal. So with this history,
so can we think about allergic or anaphylactic also?
But it is not sudden in onset, no?
Okay, sir.
And there is no exposure also to anything, correct, no?
Okay, sir.
So with this, we've got a differential diagnosis of either renal or cardiac cause, correct, no?
Yes, sir.
So, okay, fine. So we'll see what else we'll ask in our history, okay? And yeah, so you in the case of pleural effusion, there is dyspnea, no? What do you think is the cause of dyspnea?
The tidal volume reduces. Okay. Because the lung is not able to expand.
Yeah, correct. Everyone is of this false belief. That's why I asked you the question, but that is wrong. Okay, now we'll look into it. Thank you, Rishabh, for volunteering.
Thank you, sir.
Okay, so we'll see. So we have framed our case, and we'll see what other history we can ask for in a case of pleural effusion. Okay. So complaints, one is chest pain. If a primary case of pleural effusion comes, and moreover, what is important in pleural effusion is, if the patient as such comes with pleural effusion, that is when we'll have to worry, because we don't know what the etiology is. If there are other associated features, then he comes with these symptoms, then we can more so think that it is a pleural effusion related to that particular cause. Other any systemic causes or anything we think of, we can think in that way. But if it is a case of primary pleural effusion, then we'll have to go further and see what is the cause. Okay, so that is when we'll have to evaluate thoroughly. So pleural effusion as such can present one with inflammation of the pleura that causes chest pain. Next is dyspnea. Why is this dyspnea present? It is not because that lungs are not able to expand, because even a case of past TB, he would have had extensive lung fibrosis. Even that particular patient is presently breathing normally. So we can't tell that just because there is accumulation of fluid, or even a patient who has undergone lobectomy or one side lung is removed, that patient also can breathe properly. So it is not, that is not the cause. Actual cause is there is mechanical inefficiency of the respiratory muscles, because respiratory muscles are continuously stretched now. And one more is diaphragm is pushed downwards, because lot amount of pleural fluid which accumulates, that goes and pushes down the diaphragm. So that is the cause. So mechanical inefficiency of the respiratory muscles. Next, cough. Why is cough caused? One, that is because of distortion of the lung. So what are the associated features? One is transudative, other one is exudative. So if we are thinking in terms of congestive heart failure, we'll see dyspnea, we'll see cough, orthopnea, PND, peripheral edema, all those things. And CHF, it is mostly bilateral pleural effusion. Okay, in 70% of the cases, it will be bilateral. Even if unilateral, it is mostly right-sided. While again, we'll confuse that CHF because lung is on the left side, it might be left-sided pleural effusion. But no, it is right-sided, because right side there is large lung volume. So more amount of interstitial fluid accumulates on the right side, which seeps into the pleura. So right side is more as compared to left side when it is unilateral. Okay. Next, what is the mechanism? That is because of increased clearance of the interstitial fluid from the leaky mesothelial cells. So next is hepatic hydrothorax. That is nothing but ascites. So clinical features associated with cirrhosis and ascites will be present. So whatever the liver failure features that we have already done with it in our icterus chapter, so we will not deal with it. So those are the particular features you will ask for. So patients might have severe dyspnea, as there will be very large right-sided pleural effusion. Okay, so patient usually will have severe dyspnea. Okay, so and why does it take place? Because of pleuroperitoneal communications, because of diaphragmatic defects. Very, very important question in your viva. Why is right-sided pleural effusion present in a case of ascites? Pleuroperitoneal communication. And as a complication of this, there can be spontaneous bacterial pleuritis. What is this? Infection of the pre-existing hepatic hydrothorax. Whatever fluid that is accumulated in the ascitic fluid in the pleura, that will get infected. And when do we tell it is? Either when the pleural fluid culture becomes positive with neutrophil count greater than 250 cells, or if the culture is negative, cell count greater than 500 cells. Okay. Next is nephrotic syndrome. As we saw in our case, there can be history of edema, previous thrombotic attacks, hypertension on examination, all those things. Okay. And why is it caused? One is because of increased hydrostatic pressure. Second is decreased osmotic pressure. Secondly to hypoalbuminemia. Okay. Increased hydrostatic pressure because of RAS. There will be activation of RAS. Okay. And yeah, there will be usually bilateral pleural effusion we expect in the case of nephrotic syndrome. And next, we saw there is peritoneal diagnosis associated. Okay, this also will be right-sided, because usually it will be right-sided through the pleuroperitoneal communication. Next, if there is history of trauma to genitourinary tract, or if there is any prior surgical history to the genitourinary tract, or if there is something like prostatomegaly, in all those conditions, what can take place is there will be retroperitoneal urine collection can take place. And this retroperitoneal urine seeps through the diaphragm and presents in the pleura as pleural effusion. So that is what we call it as urinothorax. That is what we call it as urinothorax. Next one, myxedema. Again, myxedema, don't confuse it to be a cause of exudative pleural effusion. It causes transudative pleural effusion. Okay, so what are the associated features of hypothyroidism will be present, like fatigue, cold sensitivity, constipation, dry skin, all these things will be present. Mechanism, decreased lymphatic clearance because of decreased thyroid hormones. The lymphatic vessels won't contract properly, so there will be decreased lymphatic clearance because of reduced thyroid hormones. And what is important is look for pericardial effusion as well. Okay. Next is the pericardial disease, which we saw. So that causes, most important causes, constrictive pericarditis. In this, what happens? Ventricles won't be able to relax. When this is present, it usually presents with features of right-sided heart failure, like dyspnea, edema, increased JVP, right upper quadrant tenderness, all these things. What is the mechanism? One is because of increased hydrostatic pressure in the pulmonary circulation. Ventricles cannot relax, there will be back pressure, which will cause increased hydrostatic pressure. Next one is direct effusion from the pericardial space. Whatever fluid that is collected, there will be direct diffusion into the adjacent pleural space. Okay, and this left-sided is more common as compared to right-sided. So we saw features of what are the features you look for in most important causes of transudative. Next we'll see exudative. Exudative one is pulmonary embolism. What is important is pulmonary embolism, it can present silent, asymptomatic case. Also on doing radiology workup, you see fluid collection, or it can be present as isolated dyspnea, or it can present with pleuritic pain, or the patient might suddenly collapse. So, and it is important because we can very easily miss out the diagnosis of pulmonary embolism. We'll have to keep it in mind. What is the mechanism? It is because the thrombi which is present in the vessel wall that will cause endothelial injury, that secretes inflammatory mediators that will go and irritate the pleura. That is the mechanism. That's why it is exudative in nature. Again, pulmonary embolism is exudative in nature. We tend to think that it is transudative in nature, but no. Pulmonary embolism, because there will be no inflammation, nothing, we tend to put it in transudative cause, but no, it is exudative in nature. Okay. Next important cause is infection. So among this, one is parapneumonic effusion. So how do we expect a case of parapneumonic effusion to present? The patient will come with normal features of lower respiratory tract infection, cough, dyspnea, chest pain, all these things, fever, high grade fever, all these things patient present with. Then we might put the patient on empirical antibiotics. But even after 4 to 5 days of empirical antibiotics, either the symptoms worsen or the patient symptoms persist. Then we can think of parapneumonic effusion. Okay, so the same thing, they will be without change in symptoms during the course of the disease. Pleuritic type of chest pain he might develop and goes into sepsis, or the patient might go into sepsis. Worsening of the symptoms can be there. Then we'll have to think of a pleural effusion, parapneumonic effusion, and it can be long-standing pleural infection. Okay, long-standing means this is a chronic presentation. So what you'll have, significant weight loss, you'll have night sweats, you'll have continuous low-grade fever, you'll have loss of appetite, you'll have. In this condition, again, this is mimicking malignancy and TB. So we'll have to consider that in our differential diagnosis. Next is tubercular pleuritis. So how does this present is, it can either present acutely or chronic. Acute is, it can present as any other parapneumonic effusion because that particular lobe will be involved. And that particular lobe acts in a similar way to parapneumonic effusion. So there will be consolidation of the lobe like parapneumonic effusion, and there will be effusion on that side. Wherever the lobe is consolidated, that particular side, there will be effusion. That is how acute. One more is chronic. Chronic, what happens? The pleura itself get infected. The TB bacteria which is there, it will go affect the pleura. It causes pleuritis. Once pleuritis is there, that pleuritis will lead to accumulation. So depending on which side the pleura is affected, it can be unilateral or bilateral. So mostly it is unilateral. Okay, so either right-sided or left-sided, and it will be small size. It is just the inflammation of pleuritis is taking place. There's as such no secretion, so that will be small side effusion we expect. Okay, and what are the other features we might or might not have? Weight loss, night sweats, loss of appetite, low grade fever, all these things we might or might not have. Okay, next is abdominal diseases. So what are the abdominal diseases? One is esophageal rupture, and this one is emergency. It is emergency, so have to be treated promptly. So we'll have to diagnose it very early. One is, it is easier to diagnose because there will be history of any, most of the times it is iatrogenic cause or following vomiting, what spontaneous Borev syndrome, all those things. It is easy to diagnose, but we shouldn't miss it. Okay, a patient presenting post endoscopy, we should always think of esophageal rupture. Okay, so it has to be recognized and treated promptly, or else patient will go into sepsis. High mortality will be there. No, so what is more important is emergency treatment. Okay, so you usually expect left-sided pleural effusion. In a case of esophageal rupture, there will be left-sided pleural effusion. Why does it take place? It is because of the ruptured contents will go irritate the mediastinum. That causes acute mediastinitis. So there will be a history of trigger, like any bout of alcohol followed by vomiting or an endoscopy procedure, following which there will be bursting pain, that which is not even relieved by any painkillers. So that is how the patient presenting symptoms will be classical. We might confuse it to be an MI, but when we ask for a history of trigger, the patient tells us. So history is important again. Hematomesis, subcutaneous emphysema, all these things will be present. So next is pancreatic disease. So in pancreatic disease, what happens? Either acute pancreatitis as such can present with pleural effusion. One more is complication of pancreatitis, that is pseudocyst that is present. It drains into the pleura and presents over there as this thing. So pseudocyst, what happens is it is difficult to diagnose. Why? Because one is the pseudocyst which is there, it has drained into it forms a sinus tract and it drains into the mediastinum. So all the contents in the abdominal will be gone. So you won't have any abdominal symptoms. So only based on past history of acute pancreatitis a month back, you can diagnose it to be secondary to pseudocyst, or it can be pancreatic ascites. Okay. So if it is acute pancreatitis, we'll ask for pain, abdomen, nausea, vomiting, back pain and all. What is the mechanism? Exudates from the pancreatic inflammation and diaphragmatic inflammation. These exudates go and irritate the diaphragm. This diaphragm secretes pleural fluid, okay? Because diaphragmatic pleura will be right over there. Pseudocyst, respiratory symptoms dominate. The abdominal symptoms wane off because all the secretion inside the cyst will go off into the mediastinum, because there will be a sinus tract communication between this pseudocyst and the mediastinum. One more is it can be because of rupture into the pleura. And pancreatic ascites is acute pancreatitis leading to ascites that will go into the pleura. Okay. Next, intra-abdominal abscess. There will be again history of prior surgery, perforation, appendicitis, cholecystitis. All these things will lead to foci of infection. So that particular quadrant pain will be there, high fever will be there. So again, this is okay. This we can diagnose. What is the mechanism? Again, diaphragmatic irritation. Next is abdominal surgery. Around 50% of the patients following abdominal surgery, they develop secondary to diaphragmatic irritation only. One more is immune mediated. So they will have history, fever, arthritis, skin rash. The patient will usually be already a diagnosed case. So that won't be a problem. Mostly you'll think of SLE and rheumatoid arthritis. Why? It is because of autoimmune mediated pleural inflammation. Next is asbestos exposure. Again, there will be history, past history of exposure, occupational history. On asking for occupational history, there will be history of exposure, and usually very mild symptoms will be there. What is more important is we rule out mesothelioma. Okay, so years after exposure, the patient presents. Mechanism is asbestos particles which are there, they go and block the lymphatics. One more is they cause mild grade chronic inflammation. So next is diagnosis of exclusion, rule out mesothelioma. Okay. Uremia also, there will be features of CKD will be present. If there is uremia, there will be features of CKD. Fibrinous pleuritis is the mechanism. Post-cardiac injury, as we mentioned, Dressler syndrome, the history of MI or any cardiac surgery or any chest trauma, penetrating chest trauma. After 3 weeks, it presents with fever, chest pain and all. So in this, pericarditis also can be there, pleural effusion can be there, or pneumonitis can be there. Next is something. So next, I'll only ask you if you guys can diagnose. There was a history of chronic pleural effusion, like over 6 months. Then he suddenly developed dyspnea, so they decided to drain it, and they drained the fluid. Even after draining a fluid, after a month, the patient again presented with the same symptoms. There was again accumulation of fluid, but the initial history was because of infection, chronic infection. The infection resided because there was no continuous fever and all. In that case, what can you think of? Anyone? Think of in that case? Bishop is thinking of malignancy, traumatic. Okay, since there is a history of pleural infection, what happens is because of chronic infection, they'll develop an adhesion. The pleura, visceral pleura, will develop adhesion to the lung. So in that case, what happens is the lung won't be able to expand. Even after you remove the pleural fluid, the lung won't be able to expand. So in that case, what happens? There will be a very large amount of negative pressure that is created. No, so that negative pressure which is created, that will again cause pleural fluid to reaccumulate, which presents as pleural fluid. So the re-expansion won't take place. That is why it is called as trapped lung. It is called as trapped lung. Recurrent pleural effusion after thoracocentesis in a patient with chronic pleural effusion. So the mechanism already explained. Next is malignancy. Again, you will have this malignancy. It's usually a small-sided unilateral effusion. Again, it's a very difficult to diagnose because these features, what we see, might or might not be present. We'll see how to diagnose a malignancy later. Next, what is important is in malignancy, if it is secondary malignancy, lung cancer is the most common cause. Okay. If it is primary malignancy, then mesothelioma is the most common cause for pleural effusion. Okay, that is important. Chest pain, dyspnea, history of exposure to asbestos, all these things will be there. This is drug-induced, same set of drugs, very important to remember. So once again, I'll repeat: nitrofurantoin, dantrolene, methotrexate, bromocriptine, procarbazine, amiodarone, and dasatinib. Okay. Next, coming to examination. So we'll see the examination findings of our case. Okay, we'll go a bit faster. Anyone would like to volunteer for examination of the previous case, which we are discussing, which case we had now? So we have come to a differential diagnosis of mostly a case secondary to renal involvement. One more is because of cardiac involvement. So these are the things which we have in our mind. Okay. What are the examination findings which we'll expect in a case of pleural effusion? Anyone would like to volunteer now? If you guys volunteer, we can make it fast. Please raise your hand now or through your chat if you like to volunteer. Quick. Okay, Pawan wants to volunteer. Good. Yeah, Pawan, could you unmute?
Yes, sir.
Yeah. So, what is the examination scheme which you will follow?
So inspection, palpation.
No. Before that, what you will in a patient, you will directly jump to RS examination.
Vitals.
Even before that,
General physical examination.
Yeah, conscious, cooperative, all those things you'll see. Nourishment. It's a
Yes.
pediatric case, very important. No.
Yes, sir.
Since the patient is emaciated, okay, this patient is emaciated. Next, it's a pediatric case, you'll ask for anthropometry also, no?
Yes, sir.
So, okay, anthropometry, you will find that there is some amount of growth retardation is present. Okay?
Yes, sir.
Growth retardation is present. We can call it to be failure to thrive only. He is not gaining weight also. Now he has gained weight because of edema, but in the long run, he is not gaining weight also. So all those things are present. So failure to thrive is present. That is anthropometry. So we got this thing. Next, what we will do?
Head to toe examination.
Okay. Before that, vitals.
Vitals, yes.
Yeah, isn't it important in our case?
Important.
Yes. In vitals, what all you look for?
BP, pulse rate.
Okay. BP for this case, BP was slightly high in this case. Okay. BP was slightly high in this case. Okay. Next, you'll ask for pulse rate. Pulse rate was around 90 beats per minute. Anything else you'll look for in the vitals? Temperature, it was A for breath. Next, what you see in vitals?
Respiratory rates.
Yes, that is very important, no? In our case, respiratory rate was around 32 cycles per minute. Okay. So
Yes,
indicating that some amount of irritation is there in the lungs. So again, we are going to the pathology of the lung is present. So
yes.
Next, anything else you'll see in vitals?
Jugular venous pulse.
Yeah. Isn't JVP important? JVP is important. JVP is not raised. If JVP is not raised, still you're expecting it to be raised. What you will do next?
Hepatic.
Hepatojugular reflex, correct? No? Yeah,
Yes.
even that was not present. So, okay, fine. This was to do with vitals. Next, what to do?
Next, we'll go for systemic.
Head to toe examination.
Yes.
Head to toe examination. So, okay, pallor was not present, icterus not present, cyanosis, no, clubbing, no, lymphadenopathy, no, edema. We have already seen edema, pedal edema was present.
Yes.
Puffiness of the face was present. Okay.
Yes.
And no, nothing as such was present. Nothing else was there in this case. Okay. Next, you will go to systemic examination. Which system would you like to examine first?
Respiratory.
Okay, respiratory system. Respiratory system. What all you will see? Inspection.
Position of trachea and
first is inspection. Position of trachea. Okay, there is left side deviation of the trachea is present. Anything else you like to ask?
Whether they're equally expanding on both sides.
No, right side it is expanding less.
Yes.
Expanding less on the right side. Less expansion on right side is present. And what else you had asked for?
Then
Trachea is shifted to left.
apex.
Anything else? Okay, apex beat is shifted more laterally. Apex beat is shifted more laterally. Apical impulse. Okay.
Then whether any dilated veins are there.
Okay, dilated veins were not present. Spurti is asking any visible fullness is present. Yes, right sided in the mammary region there is fullness. There is, you can see the fullness present. Intercostal muscles bulging is present on the right side.
Yes.
So this is present.
Okay.
Okay, strains of steroid toxicity, but this kid was given steroid just for one episode of that nephrotic syndrome. The kid was given steroid, so he is not on chronic steroid yet. Okay, so that is not present. Okay,
Sir,
anything else?
Accessory muscles.
Use of accessory muscles, as of now, it's not there.
Yes.
So almost everything you've covered, no? Chest movements over, trachea over, apical impulse over, chest movements over, and you look for fullness, any asymmetry you've seen. Okay, everything is fine. Next, what do you do?
Palpation.
Okay, good. Next is palpation. After inspection, palpation. So you just confirm the inspectory findings, no? So what you will do?
Then we'll go for.
So again, trachea is shifted. Apex beat is also shifted. Anything else in palpation? No. Measurements you will do, no?
Yes, sir. Measurements.
So measurements, what you will do? Inspiration
Right.
and expiration, no? So
Yes,
left hemithorax expands more than right hemithorax.
Yes.
Anything else in palpation?
Tactile fremitus.
Yes, tactile fremitus is reduced on right side, inframammary region, infrascapular region, axillary, infraaxillary region, all those places, tactile fremitus is reduced.
We'll go for percussions.
Okay, you'll go for percussion. Okay, percussion. What do you expect now with these findings? What can you expect in percussion?
Will dull note in inframammary, infraaxillary, infrascapular regions.
Is it just a dull note? Dull note will, even a consolidation can come with dull note.
Stony dull.
Okay, you guys call it stony dullness. Fine. Stony dullness is present in the same region where tactile fremitus was not there. Stony dullness as well was present. Okay.
Yes, sir.
So next, what do you do?
Auscultation.
Good. Next is auscultation. So auscultation, what do you expect?
Increased in.
What happens to the breath sounds?
Breath sounds will decrease, sir.
Yes, reduced breath sounds were present in the same regions. Reduced breath sounds were present. Okay.
Yes,
Anything else you look for in auscultation? Friction rub. Very good. Friction rub. You'll see whether there is pleuritis. You'll have to look for friction rub. No, there was no friction rub. Pleural rub was not present. No added sounds were present. So next, what you will do? Good. Pawan, vocal resonance. What can you expect in vocal resonance?
Decrease sounds.
Decreased sounds you can present. Okay. Can you hear something like bronchophony, egophony, anything? Do you expect in a case of pleural effusion?
No, sir.
No. Pakka?
Yes, sir.
Okay. You don't expect bronchophony or egophony. Okay. Vocal resonance in this case, anyways, it was reduced. So any other system examination would you like to do?
To rule out kidney, we'll do parabdominal case.
CVS, don't you want to do?
Yes,
because a very close differential diagnosis we have, no?
Yes.
Yeah, CVS, nothing else. Again, only apex beat was shifted. Nothing else was found. Next, you will do abdominal examination. What you like to find? What you will find in an abdominal examination in this patient?
Sir, we will check if there is ascites.
Yes, you will check for ascites. So, what you will expect if there is ascites?
Fluid thrill. If it is there, we'll.
Okay, fluid thrill, shifting dullness. Depending on the amount of fluid that is there, you can have shifting dullness, fluid thrill. Okay, puddle sign. So you guys need to know that. Okay, you guys read up that. That is important. Abdominal examination. That okay, some amount of ascites was present. Some amount of fluid collection in the peritoneum was present because on percussion there was dull note, shifting dullness also was present. Okay.
Yes.
Anything else you want to ask? There is no tender hepatomegaly. There is no hepatomegaly, splenomegaly you will ask for, no? Yes, good, Rishabh. There is no hepatomegaly, okay?
So is kidney palpable or?
Kidney is not palpable. So anything
Renal
else?
tenderness.
Hmm?
Renal tenderness.
Renal tenderness is not present. So you wanted to rule out infection. Okay, not present.
So,
Okay.
sir, I'm thinking, yes, sir.
So done. Now, finally, what you will think of in your diagnosis?
Sir, nephrotic syndrome, which might have caused ascites, and that is leading on to right-sided thorax.
Okay. You are thinking of nephrotic syndrome leading to ascites, leading to right-sided pleural effusion. Without ascites, can you have pleural effusion, this patient?
This patient, I don't think so, sir.
Okay, a case of nephrotic syndrome. Is it
Yes,
possible?
sir.
Huh?
Yes, sir. It's possible, sir.
It's possible. How? Yeah,
So
hypoalbuminemia is
protein
the
will be less.
second reason. First important reason is
Ascites.
no. Increased hydrostatic pressure followed by hypoalbuminemia. Okay.
Yes.
Any other differential diagnosis you'd like to consider?
No, sir.
Hypoproteinemia due to malnutrition. Okay, that also we can consider. But given his past history, we will go more in terms of nephrotic syndrome only. Okay. So,
Yes,
Pawan, okay, Pawan, thank you. Okay.
thank you, sir.
Okay. So now whatever we have done, just to sum it up. So just what is important to pleural effusion have mentioned over here. So minimum 200 to 300 ml is required to detect clinically, but in an MCQ, please go for 300 ml. Okay, go for 300 ml if asked in MCQ. So clinically, to detect pleural effusion, 300 ml of fluid should be present. Very important point. Next, inspection. So what do you find? Whatever Pawan had told, trachea might be shifted, apical impulse can be pushed away, whichever side pleural effusion is, to the opposite side. Fullness of the chest with bulging of intercostal spaces can be there, diminution of chest expansion, and diminution or absence of intercostal retraction. So these are the findings you expect on inspection. Palpation, you will confirm the same. All those things you will confirm. Confirmation of mediastinal shift, reduced chest expansion, vocal femtors will be reduced. On percussion, flat note on percussion you will note. Okay. For this, again, 200 to 300, but 300 ml is a better answer. And top space, if pleural effusion is on the left side, it will be flat note. So what is important is, yeah, we can tell it is stony dullness. In our external exam, we go ahead with stony dullness. When do we tell it is stony dullness? How do you tell it is stony dullness? Because dullness and stony dullness both sound the same, no? What is characteristic for stony dullness? Anyone with the answer? So when we percuss, pain on percussion or resistance should be present. That is when we call stony dullness. And this classical stony dullness, it is usually present when there is a hard mass beneath the percussion side. When there is a hard mass, only then. So if there is a tumor underneath it, solid tumor, then we can call it to be stony dullness. For pleural effusion, usually it is a flat note because there is not such hard mass beneath it. But under usual circumstances, in most of the standard textbooks, it's Golwala or any other textbooks, it mentions flat note on percussion is for pleural effusion. Okay. So, but in your external exam, continue with stony dullness. You can tell it's stony dullness only, but for your information, it is flat note. Okay. Next important question that they can ask in our Viva is, how do you differentiate pleural effusion from hydropneumothorax? Okay. One is based on fluid level. Over here, because of capillary pressure, the axillary side will be higher than the opposite side. So there will be a shaped curve of ellipse will be noted in pleural effusion. But over here, the upper level of dullness will be horizontal in hydropneumothorax. Next is succussion splash. Succussion splash, what happens? It is present in the case of hydropneumothorax, and shifting dullness is also present in the case of hydropneumothorax. Again, this is a controversy. Shifting dullness is a controversy because it may or may not be present in pleural. If it is a very small pleural effusion, it's not present. If it is moderate to high amount of pleural effusion, then we can still expect it to be present. Okay. So this is how we differentiate. And based on the amount, Kundu says that if it is around 500 ml, it is mild. 1000 to 1500 ml, it is moderate, and greater than 1500 ml, and high pleural effusion. Okay, mild, moderate, and severe pleural effusion based on the amount. This is what Kundu tells. Okay. Next, how we differentiate pleural effusion from hydropneumothorax. Very important. 3 things. Mainly it is fluid level. Horizontal, and over here curve of Ellis will be present. Next is succussion splash. Succussion splash we don't expect in a case of pleural effusion because there is no air fluid level. Only if air fluid level is present when you shake a person, when you keep it at the upper level of dullness, then you can expect a succussion splash to be present. So for that, air and fluid level should be present, which is present in hydropneumothorax. Okay. Next is shifting dullness, might or might not present in pleural effusion, but hydropneumothorax, every case it is present. How do you elicit is a question. Again, please read up. Okay. Next is something called as Grocos triangle. Anyone aware of it? It is the area of dullness which is present over the back of the chest on the side opposite to pleural effusion. So what happens over here is, one side there will be pleural effusion. That pleural effusion, what it does is it will push the mediastinum to the opposite side. So posterior mediastinum which is there, that will start sounding dull on percussion. Correct? No? That is what we call as Grocos triangle. One more is Garland's triangle. This is not of much significance. What happens over here is, when there is moderate sized pleural effusion, the lung which is there, which it floats upwards and backwards. Lung floats upwards and backwards. So the lower part will be relaxed. When the lung floats upwards and backward, the lower part of the lung, it will be a bit relaxed. So that comes into the area of percussion, and that seems resonant. Okay. And this is what you call it as cardiac resonance. What happens is there will be some amount of pleural effusion. When that happens, the lung will start floating. So by nature, because of gravity, upwards and backwards it will float. So the whatever is floating backward, the lower part, it is still relaxed. So that area appears resonant, and this is called as cardiac resonance. We will expect dullness in that area, but that area becomes resonant because of the backward part of the lung that is present, and this is only what we call it as cardiac resonance. Auscultation, again, absence or reduced air sounds will be there. Vocal resonance, absence over the area, and in the upper border we can expect to hear bronchophony or egophony. Egophony is nasal intonation. This will be present because some amount of fluid will still be present between the upper border of resonance or the upper border of dullness. Some amount of fluid will be present between the lung and the place we focus from, place we auscultate from for vocal resonance. So that is why we get egophony. Second one is bronchophony. Why? Because lung will be collapsed at the upper level because of fluid. Lung will be collapsed, and if a bronchus directly drains into that area, we will expect to hear bronchophony. We over here will hear voices louder than what we are supposed to hear when the person whispers. So predominantly right-sided effusion. This is again viva question. Ascites, CAPD, Meek syndrome, subphrenic abscess, usually right-sided, and predominantly left-sided. When do you expect? When we have esophageal rupture, or when we have Dressler's syndrome, or when we have pancreatitis or pseudocyst, or when we have left-sided abdominal abscess. This is when we can expect a predominantly left-sided effusion. Okay, and this is again a very important viva question. Trachea is shifted to the same side of effusion. Is this possible? Anyone? Is it possible in case of collapse or fibrosis? Yes, good. Loculated collapse or fibrosis. So what happens is, if there is some amount of, like, in case we will take it to be a endobronchial growth is there. When that is there, that part of lung will collapse because there is growth in the bronchi. There is no air growing into it. That part of lung will naturally collapse. So when this happens, there will again be negative pressure generated. So even though there is pleural effusion pushing it to the opposite side, the negative pressure which is there, that will pull the lung. So this pulling of the lung to the same side will cause the trachea to shift to the same side. Okay. So this is what, when there is a endobronchial growth, or if there is that particular side fibrosis is present, that even in that case same thing will happen. Okay. Or if there's a loculated effusion also, then also we can expect. Correct. Next, trachea remains in the midline. When does this happen? There is no shift. Yes, very good. It happens in case of bilateral pleural effusion, or it can happen in this also. When the pulling force and the pushing force both are equalized, then we can expect it to be in a midline. Okay. And following this, we expect a very thorough systemic review. Has to be done for the patient. Okay. So next, coming to the investigation. So we'll see about our patient now. What is the investigation we'll have to do in our patient? Okay. So we have done examination. moving to the investigation. So what are the investigations you like to do? It's a case of pleural effusion, no? So, okay. Anyone would like to volunteer for investigation? Please raise your hand. Anyone would like to volunteer? One is the investigations we do for nephrotic syndrome. Other is the RS investigation for pleural effusion. Okay. Okay. No one is. So one is the set of investigation for nephrotic syndrome. So this will tell us. Let me be direct. So there is proteinuria is present. There is hyperlipidemia. There is proteinuria, there is hyperlipidemia. So this will confirm that it is a case of nephrotic syndrome which is in relapse. Okay. Next, for pleural effusion, what are the set of investigations you do? Okay, Pawan. Yes, good. So the first thing is in pleural effusion, first thing we do is we'll have to confirm whether it is a case of pleural effusion or not. Correct, no? So for that sake, first we'll do imaging and confirm whether it is pleural effusion or not. So it can either be a decubitus X-ray or ultrasound. So in this condition, there was right-sided pleural effusion. Right-sided pleural effusion was present. Right-sided pleural effusion was present. Okay. Next, what do you do? Next, what do you do? Now you confirm there is pleural effusion. Yeah, ultrasound or through chest X-ray, decubitus, Rishabh will confirm. Next one, what do we do? What is the next investigation? Yes, good, Pallavi. Pleural. We'll have to do a diagnostic thoracocentesis. We'll have to do. Go ahead and measure. Do pleural fluid analysis. In pleural fluid analysis, what is the aim of doing pleural fluid analysis? First aim is what? We saw in the starting. It is to classify. Yes, very good. It is to classify whether it is transudative or exudative. Good. So now what all you'll ask for to know whether it is transudative or exudative? In an analysis, what all you look for? Yes, good. It is pleural fluid. Yeah, we'll come to that criteria later. It is one is pleural fluid protein, other one is pleural fluid LDH, pleural fluid protein and pleural fluid LDH. These are the two things you do. Pleural fluid protein was around 6 grams per deciliter. LDH was around 120 units per liter. 120 units per liter. So now what do you think it is? If you want serum protein also, we'll give serum protein was also 6 grams per deciliter. So now what has happened? So yeah, all of you are telling it's a exudative cause. Good. It is exudative. You have used Light's criteria. What is Light's criteria? We'll do it later. It's an exudative cause. Good. So next, what do you do? What you would have actually expected in this case? Pawan told it is a case of nephrotic syndrome which has led to pleural effusion. But if it was a case of nephritic syndrome which has led to pleural effusion, we could have expected it to be bilateral. Then he told it is secondary to ascites. So we accepted it, right-sided pleural effusion. Even then, we would have expected it to be a transudative in nature. But it has become exudative now. Our analysis has become wrong. So somewhere we are going wrong. What has happened? Why are we going wrong? Anyone? So next, what do you do next? In what else you will ask in pleural fluid analysis? Okay, you're going into Rod's criteria. No, it was in fact an exudative only. We have not mistaken it to be a transudative fluid. No diuretic has been used, nothing in this patient. Okay. So you'll think of cells, you'll think of next you'll see WBCs. WBCs were around 10,000 cells were present. 10,000 cells were present. And differential leukocyte count, mainly it was They mainly differential count showed mononuclear cell infiltrate. Mononuclear cell infiltrate was present. Okay, very good. Spurti, you asked for appearance. You guys should have asked for it in the starting only. Appearance, it was around reddish to brownish color fluid. Reddish to brownish color fluid was there. In between it was. And RBCs were also noted. RBCs were also noted. Some amount of RBCs were also noted. So next you are going to infective cause. Good. So for infective cause, you'll have to do culture and staining. Culture and staining, but what we saw was negative. Culture and staining both turned out to be negative, and there was no history of fever also. Good. So these are the things you have ruled out. You have ruled out many things now. You have ruled out infection. You have ruled out. Next, what do you like to do? Wrong technique of aspiration. Even on repeat aspiration, we got the same thing. Pawan. Even on repeat aspiration, we got it to be exudative in nature only. Next, would you like to go for anything else? When something like this has happened, what you'll go for? You'll look for glucose, pH, anything you like to look for. So these were the basic set of investigations you asked for through pleural fluid analysis. After this, you'll have to ask for some other things through pleural fluid analysis. What are they? Okay, they are even higher investigation. Even higher investigations. Okay, we can, nothing wrong to expect TB because the patient will be immunosuppressed. It's a case of nephrotic syndrome. He can have TB, very good. It is, before that, you will ask for pleural fluid glucose, pleural fluid pH. If you would have seen this, you wouldn't have asked for ADA. If it is a case of TB, yes, you agreed. There was polymorphonuclear there was lymphocytosis, sorry, mononuclear cells were raised. So there is lymphocytosis. You're thinking of TB, good. But pleural fluid glucose, there was no change. It was around 70 grams per deciliter. It was fine. pH was also not raised. pH was 7. pH was not decreased. pH was 7.2 only. pH was normal. So now there is no requirement to do ADA. Even then, ADA levels were normal, within normal limits. It was not raised. So next, what do you like to do? What are you suspecting in this case? You guys are missing out something. Amylase were normal. Why amylase, Purti? There is no pancreatic cause. Even salivary amylase also can't be raised because there is no esophageal perforation. Nothing is there, no? So what are you guys missing? Echo. Why echo, Rishabh? On doing echo was fine only. His cardiac was fine. Bacteria have ruled out. Culture and staining was gone. Connective tissue disorder, you guys are now you're coming to next differential diagnosis of connective tissue disorder. But don't know why you've told it, Pawan. Okay, fine. Connective tissue disorder, according to Pawan. Would you like to do any other investigation now? Next, what do you do when it has come out like this? When you are having no clue, you can only think of 3 things in such conditions. You guys missed out cytology over here. But we cannot expect malignancy in such a young kid. Okay, no, cytology also was also negative. Okay, you can only expect 3 things. One is TB, one is malignancy, and the other one which will fetch a diagnosis. ESR was not raised, ESR was fine, there was no acid-fast bacilli, so acid-fast staining, no, not fungal. ANA profile. ANA profile, okay, ANA profile you like to do over here. ANA profile was also negative for ANA. What are you guys missing out? I think so. You'll have to go for some imaging modality now. It is a case of nephrotic syndrome that we have confirmed by a diagnosis. So there is some side effect of nephrotic syndrome, which you'll have to think of. What CT, Rishabh? What sheet you want to do? Okay, this was the finding. This was the chest X-ray finding in our case. This was the chest X-ray finding in our case. There is some right-sided moderate grade pleural effusion. S-shaped curve of Ellis is present. Everything is fine. Moderate right-sided pleural effusion is present, which you confirm by doing chest X-ray and ultrasonography. Then you did this thing. Yes, Sharanya told CT angiography. Okay, you guys did CT angiography and you guys found this. What is it? Yes, so what is it finally? Pulmonary embolism. Very good. Finally, it is a case of nephrotic syndrome, which has led to ascites, no doubt, but this ascites is not the cause for pleural effusion. Over here, it is a prothrombotic complication. Pulmonary embolism, which is caused. It is a case of pulmonary embolism. So when it is not diagnostic of any, see over here there is saddle thrombosis present and there is pleural effusion also. There is right-sided pleural effusion also present. Correct? No? On doing CT pulmonary angiogram. So what is important is three very misguiding thing is one is TB can escape, malignancy can escape, and pulmonary embolism can escape the diagnosis. So our case was a case of pulmonary embolism. So it's 8:30 to do with investigations. Again, it will take more time. So since we are doing with the case, it took off time. Can we do the investigations in the next class? Is it fine? Why reddish brown? Pulmonary embolism will have reddish brown fluid because there will be RBCs, increase in the RBCs. Pawan has the energy to listen. Does everyone have the energy to listen? It will become a very long class. Okay, most of you want the class to be continued. Yes, sir, is for what? Ringer lactate is already telling thank you, is ready to go off. This yes, sir, was for what? Is it for me to continue the class or for next class? Yes. Okay. But ringer lactate, other than you, everyone wants to continue. What can we do? So ringer lactate can see it through the recorded YouTube video then. Okay. I have to go with the majority ringer lactate. I don't know what your name is. Okay, fine. So investigations. So coming to investigations, first thing what we saw initially was we will confirm it whether it is pleural effusion or not. So how do we confirm it? One is because see, fluid accumulates. Where does the fluid accumulate? It accumulates in the most dependent part. So where is it? It is in the, initially it will go accumulate in the between the lung and the diaphragm. So the inferior surface of the lower lobe and the diaphragm, it accumulates. After that, what happens? It slowly goes seep into the place between the posterior diaphragm and the pleura. So this you can see how, because posterior costophrenic angle will get blunted on doing lateral chest X-ray. So first, this finding, it is very difficult. It is very difficult to find this through radiology. Next, we can visualize it to lateral chest X-ray, posterior costophrenic angle gets blunted. Even then, if you cannot find, we'll go further. Sorry, after that, what happens? Once posterior costophrenic angle gets filled, it will slowly seep into the lateral side. No, next is the lateral costophrenic angle will get blunted. So lateral view followed by PA view. Okay, that is what it happens. That is how the fluid accumulates. And what are the minimum fluid requirements for it to be seen? One, it is in the lateral decubitus X-ray is very, very sensitive. Even 5 ml of extra fluid is present. If the X-ray is taken properly with good exposure, it can detect. Okay. Next is ultrasound. Around 50 to 60 ml fluid, if it's present, USG detects it. Next is 75 ml. 75 ml of fluid will go blunt the posterior costophrenic angle. So we expect on lateral view of erect X-ray, it will get posterior costophrenic angle will get blunted. Next one is around 175 to 200 ml fluid. This on PA view also you will see, because the lateral costophrenic angle which is there, that gets blunted. Okay, so these are the chest X-ray findings. One is the blunting of posterior costophrenic angle, as the arrow points, this angle is blunted over here. Next, on doing erect X-ray, you find S-shaped curve of Ellis, S-shaped curve of Ellis because of the capillary movement of the fluid. Okay, yeah, Rishabh, above the normal levels. Normal level is what, hardly 10 to 20 ml of fluid is present. Next is, yeah, these are the findings that is suggestive of pleural effusion, because the chest, erect chest X-ray, what happens is there can be a consolidation in this place, or there can be a consolidation in this place. This consolidation also can mimic, blunt the lateral angle and can mimic pleural effusion. So we can tell that this is just suggestive. How do we confirm it? Is with either a lateral decubitus chest X-ray or ultrasound. Lateral chest decubitus, if there is pleural fluid, there will obviously be movement. So this is what we find. See over here, the arrow mark shows, or ultrasound confirms it. Ultrasound is a very good modality. Okay, to confirm pleural effusion, ultrasound is very good. Next, what is this? What are these two images show pointing towards there? Quick. What are these two imaging modalities? What are they pointing towards? Pleural thickening dish abscess. See, it is D-shaped. Both are D-shaped. This also, this also. What is this D-shaped? This is, yeah, empyema. It is more so loculated pleural effusion. Empyema, you can't tell until and unless you do a thoracocentesis and find pus. You can't tell whether it is empyema or not. Pawan, very good. It can as well. This can be a malignant foci. That's why chest X-ray erect is not diagnostic. It is suggestive of. Okay, this is the D-shaped loculated pleural effusion. Ultrasound, what is the use? It can be confirmed by ultrasonography. It is better than CT scan because it is cost effective and less radiation exposure is there, and it can let us know what is the site of thoracocentesis. And USG guided small and loculated effusion, it can find out. USG guided for small and loculated effusion, USG guided thoracocentesis can be done. Even this thoracocentesis, either you mark the site, you can directly do percussion, you find the upper fluid level and then do, okay, fine, or you mark the site through ultrasonography and do, or when it is loculated pleural effusion or a very small pleural effusion, then we'll have to go ahead and do a USG guided pleural effusion. Okay, next is CT scan. So best way to visualize pleural space is CT scan. Just that it is a costly investigation, but it is the best way to diagnose, or visualize the pleural space. It helps us again to differentiate whether it is a parenchymal abnormality or a pleural abnormality. So whether it is a malignant mass, or whether it is a consolidation, or it is primary pleural abnormality only, or it is a pleural thickening, or it is because of effusion. CT scan helps us to differentiate. And again, if we are suspecting if we have a unilateral large effusion, then we'll have to suspect a mass. That time again, CT scan will be helpful. Then very important is to differentiate empyema from abscess. So in this, which is empyema, which is abscess, which is lung abscess, which is empyema. A and B is there. Which is empyema, which is lung abscess. Yes, good. B is abscess, A is empyema. So how do we tell it is? One is lenticular shape. Empyema will be lenticular in shape. As we see the shape over here, this will be rounded. Lung abscess will be a rounded mass. Next one is air fluid level will be usually present in lung abscess as compared to empyema. Okay. Next is surrounding lung is often compressed, but lung abscess arises from the lung, inside the lung itself. So you cannot make the margins. Boundary cannot be made out distinctly. Next is margin of collection creates obtuse angle. Very, very important point. It creates an obtuse angle. So we see over here, it creates obtuse angle. Again, over here, it is creating an obtuse angle, but over here, it is an acute angle. Here we see again, what you see over here, it creates an acute angle. No? So this is important. Next is the thick, smooth wall and thick, irregular wall. No vessels can be seen close by. Vessels passing through or the near collection can be found. So This is how we differentiate lung abscess from empyema. Next is thoracocentesis. Thoracocentesis can be diagnostic as well as therapeutic. Okay, as diagnostic therapy. So when do we do thoracocentesis? Once it is confirmed, then we'll have to go further and go further ahead and do a diagnostic thoracocentesis. And when will it yield? Is when there is greater than 10 mm of fluid on lateral decubitus or USG. See, okay, you did the lateral decubitus. If over here, if it is this width is greater than 10 mm, then we can go ahead and do thoracocentesis. Then we will get a good yield of fluid for us to do a diagnostic thoracocentesis. Even by ultrasound, you can do that. Okay, so this is what we do. How do we do procedure? We drain around 50 ml of fluid to be drawn. So first we confirm the site either by doing ultrasonography, or you go do percus, go through the upper border of dull disc, come 2 spaces, intercostal spaces behind, and you drain the fluid. You go to the upper border of ribs. You go whenever you have a breakthrough, when you get a free space, sudden breakthrough when you start collecting around 50 ml of fluid to be collected. So that is what is explained over here. And what are the complications? Pneumothorax, hemothorax can be a complication. Okay. Next is pleural fluid analysis. So next investigation will be pleural fluid analysis. So what are the basic tests to be done? One is the appearance. Second one is pleural fluid protein and LDH levels, glucose levels, differential count, microbiological study, and cytological study. Okay. So what are the higher tests that we do? pH, amylase, ANA profile, rheumatoid factor, ADA, interferon gamma, lipid levels, all these things we do. So based on appearance, these are the findings. If it is pale yellow or straw colored, we'll think of transudative. If it is red or bloody in nature, you can think of pulmonary embolism, trauma, any infection, pulmonary infarction, all those things. If it is greater than 50% of blood, peripheral blood, then we think of a hemothorax. If it is 1 to 50%, it is either the hematocrit, what we are telling, malignant, or pulmonary embolism we can think of, as we saw in our case. If it is milky, then it is obviously chylothorax or cholesterol effusion, pseudochylothorax. If it is brown, it can be either chronic blood or ruptured amoebic liver abscess, Anchovy auspus. Black is Aspergillus niger. Yellow-green, rheumatoid pleuritis. So in this way, pus, if you see, it is empyema. Next, if there is urinothorax, Anchovy sauce, amoebiasis, urine, you will get the smell also, no? Smell also is important. And if it is water-like, it is CSFO due to abnormal communication. Next is pleural fluid protein. It is increased in all the exudative cause. Pleural fluid protein, we can expect it to be increased. So very low levels, around less than 0.5 grams per deciliter when it is there. Like usually, normally we expect it to be around 1 to 1.5. Then we can think the source to be other than the pleural fluid itself, like CSF, urine, or CAPD. Next is, if it is greater than 5 grams per deciliter, we can think of tuberculous pleuritis. If it is greater than 5 grams per deciliter, most of the times it is tuberculous pleuritis. Okay. And then comes the why pleural fluid is elevated. It is because of increased capillary permeability. So this we know. Next is LDH. LDH is because of increased vascular permeability and increased degree of cell turnover. Either vascular permeability is more, or there is increased metabolism. One of these causes increase in LDH. Okay, so it is increased again in all exudative causes. Even serial measurements of LDH is more important because it tells us about how the disease is progressing, whether it is resolved or whether the disease is increasing. Okay, as in case of infection, if the bacterial activity is more, LDH levels increases. If the bacterial activity reduces, it decreases. So the serial measurements are of more important. So if on doing pleural fluid analysis, it meets the Light's criteria for LDH, but not the protein, then what do you think of? What are the two differential diagnoses that has to come to your mind? LDH levels are normal, but not LDH levels are raised, but not the protein. That means the activity is inside the pleural fluid itself. It is not anything from outside inflammatory activity. So what can you think of? The two causes you can think of are malignancy and pleural effusion. Okay, malignancy and pleural effusion. Sorry, parapneumonic effusion. Parapneumonic effusion you can think of. So next is glucose. Glucose less than 60 grams per deciliter, milligrams per deciliter. This is very, very important. Three most important causes are parapneumonic effusion, malignancy, and rheumatoid arthritis. These are the, along with tuberculosis, these are the most important causes. Three main causes are this, along with tuberculosis. So whenever glucose is reduced, please think of these four causes. Other causes can be hemothorax, paragonmiasis, Church-Strauss syndrome. All these things can be there. Next is white cell count and differential count. So normal is around 1500 cells per millimeter cube. If it is less than 1000 cells, we think of transudative fluid. If it is greater than 10,000 cells, we'll think of exudative, mainly tuberculosis, empyema or parapneumonic, secondary to infection, malignancy, and then comes pulmonary embolism, autoimmune disorder, pancreatitis. All those are later we'll think of, mainly we'll think of these three causes. Okay. Next comes the differential count. If it is neutrophils, then we think of any acute process. Okay, like pneumonia, pulmonary embolism, pancreatitis, abdominal abscess, all those things. If lymphocytosis is there, then some chronic cause should be there. Mainly, very important, two things is tuberculosis and malignancy. We think of tuberculosis and malignancy. Next, we saw that in that case, I think so, lymphocytosis was raised. We can think of pulmonary embolism. What are the other causes? Will be pulmonary embolism or any autoimmune disorders. All these things can be there. But mainly it is tuberculosis and malignancy. Next, eosinophilia. This is a very, very important MCQ. Okay. After excluding air and blood in the pleural space, after excluding this, what are the other causes you will think of is very important MCQ point for us. Pneumothorax, hemothorax, and post-thoracocentesis will come in this only, air and blood. Other than that, what is important is malignancy. Next is parapneumonic effusion. Next is pulmonary infarction, tuberculosis, pulmonary embolism. Okay, this is not that important. Drug-induced and Church-Strauss and paragonmiasis. Okay, these things are very important for our MCQ. Malignancy, pulmonary infarction, parapneumonic effusion, tuberculosis, pulmonary embolism, drug-induced, and these two, paragonmiasis and Church-Strauss syndrome. Next, you do pleural fluid cytology, but the problem is pleural fluid cytology is it can vary from around 25% in Hodgkin's disease to 90% in adenocarcinoma lung. So there are various malignancies and the yield can vary. Okay, so that is why we cannot just confirm on cytology. We should go ahead and do a needle biopsy. Needle biopsy is important. Invasive procedure is important when we are thinking of malignant cause. Next is, if you're thinking of infection, then you can do staining, gram stain or acid fast stain, culture, and antigen detection has to be done. If pleural fluid pH, before that, okay, fine, let's look into this case. Pleural effusion is positive by doing radiological examination. Thoracocentesis shows this. So these two things will tell us that it is of transudative in nature. Fluid is transudative in nature. Cells also tell us that fluid is transudative in nature. It is not an infective process. Pleural fluid glucose is normal, but pH is reduced. What can you think of in this condition? Anyone? It is a transudative fluid with low pH. Usually you don't expect low pH in a transudative effusion. Okay, next, it smelled of urine. Now anyone can tell? Main hint was it smelled of urine. It is a case of urinothorax because it is a transudative fluid. pH is low. pH is low, no? That's right. Okay. So these are the important causes of low pH. Low pH. Again, what is important in this is parapneumonic effusion, esophageal rupture, rheumatoid arthritis, tuberculosis, and malignant pleural effusion. If you remember this, it's enough. These are the most important causes. Okay. Next, what are the invasive procedures? Till now we saw, but even after this, most of the cases might not be diagnosed. Not most, around 30 to 40% of the cases might escape diagnosis. When we think of this, only three things should come to our head: malignancy, tuberculosis and pulmonary embolism, as we saw just now. Pulmonary embolism, you do a CTPA and you find out. Okay, fine. But how do we find out whether it is malignancy or TB? One is worsening. One is by doing invasive procedure. So when are this indicated is when there is worsening of symptoms, when no diagnosis has been, we have been able to make out no diagnosis, followed by worsening of symptoms, pleural fluid LDH continues to raise, and patient is anxious about his symptoms. This is when, because like around 30 to 40% goes undiagnosed. Even after doing invasive procedure, around 20% remains undiagnosed. But those things usually reduce on its own. Okay, so if the patient is anxious, then we'll do, or else we'll usually wait and monitor LDH levels, and you'll look for symptoms. Okay, usually in 1 or 2 months, it reduces on its own. So what to be considered is malignancy and tuberculosis. Okay, so how do we do? What are the invasive procedure? One is needle biopsy of the pleura. If it is tuberculosis, it is very good. Needle biopsy of the pleura is good for TB, not that good for malignancy. Okay, so TB, it gives a good yield. Around 60 to 80% of the cases we will find granulomas. And one more thing is, it can be sent for culture and sensitivity also. So drug sensitivity we get to know. So for TB, needle biopsy is good. But for malignancy, again, we don't know where to go and get the biopsy, correct? No, so only 40 to 60% of the cases becomes positive. So better modality in case of malignancy is image guided pleural biopsy, either CT guided or video assisted thoracoscopy. Okay, so this is it. These are the investigations we'll think of. First one is radiologically confirmed. Second, do pleural fluid analysis, do CTPA, and do invasive procedures. So now you guys only carry forward. So I've given a set of cases. These are history and examination, suggestive of, so this is how we approach. History and examination is suggestive of pleural effusion. Confirm with imaging by doing USG or lateral chest. Usually you do USG. Current trend is to do USG because you can simultaneously mark the site as to where you can do thoracocentesis also. So these are the two cases. On doing thoracocentesis, you find these two things. Next, what do you do? This is case 1, this is case 2, which is what is case 1, what is case 2, because we'll have to categorize it into transudative or exudative immediately after doing thoracocentesis, correct? No, using what is called as Light's criteria. So anyone, what is 1, what is 2? Using Light's criteria. By using Light's criteria, we'll find that this is transudative. 1 is transudative, 2 is exudative. Good. So how do we do it? How do we do it? Is by doing, one is ratio between pleural fluid protein and serum protein. The ratio will be greater than 0.5. Pleural fluid LDH and serum LDH. Ratio will be greater than 0.6. Okay. Pleural fluid LDH values greater than 2/3 of the upper normal limit of serum LDH. Okay. If any one of these criteria is positive, we will think of exudative. If none are correct, you will think of transudative. Okay. So next we'll go into transudative. So this is the case. 65-year-old, worsening symptoms of dyspnea since 6 months. Orthopnea is present. Okay. JVP is raised. Air entry is reduced in the basal regions. Flat note on percussion noted. Chest X-ray reveals this. This is the chest X-ray finding. In chest X-ray, what you have? Pleural effusion. You have Curly's lines over here. You have Curly's lines over here, indicating there is pulmonary edema along with pleural effusion. But on doing thoracocentesis, this happens. What happens on doing thoracocentesis? Pleural fluid protein is more. LDH is fine. Serum protein is this much. If you take a ratio, it comes greater than, it comes around 0.6. Light's criteria is fulfilled for a case of congestive heart failure. What has happened? Why has this happened? Anyone? He was treated with some drug. No, he was treated with some drug. He was given diuretics. Yes, he was given diuretics. So, yeah, good. So, Light's criteria fails when diuretics is used, because diuretics will push off the fluid, only the protein remains, correct? No, that's why Light's criteria cannot be used. So what can we do in such cases? What can we do? Okay, we'll see what can be done, how to confirm whether it is transudative. Why was CT scan done in this patient? For this, Rishabh's answer comes into place. If there's a case of nephrotic syndrome and a case of congestive heart failure, do a CT scan because there can be pulmonary embolism. Okay, around 30% of the cases, pulmonary embolism will be present. That is why over here we just saw thickening is present. Interstitial thickening is present because of pulmonary edema. Okay. So what are the pitfalls of Light's criteria is in 25% of the cases it misidentifies transudative and exudative. Okay, transudative to be exudative, it misidentifies. One more is in case of diuretics you can't use. So in such cases, what you do is the protein concentration, what is there, we differentiate the protein concentration of serum from pleural fluid. If it is greater than 3.1 grams per deciliter, one more is instead of protein we use albumin and the difference is greater than 1.2 grams per deciliter. And if pleural N-terminal pro-brain natriuretic peptide, if this is greater than 1300 picograms per ml, then we can call it to be transudative, and if this is positive we can tell it to be a cardiac cause. Okay, so let's look into this case. A 45-year-old gentleman, alcoholic, diagnosed to have cirrhosis, comes with complaints of dyspnea, catching pain on inspiration and fever. Ascites was present, right-sided pleural effusion was present. This is the chest X-ray, and this is what you find on thoracocentesis. What is the diagnosis? Okay, this is the case. Anyone with the diagnosis for this? Okay, the session has become long. All of you are tired. We'll wrap it up. Few more cases for approach. Yes, Purti, very good. It is spontaneous bacterial pleuritis. Spontaneous bacterial pleuritis. Again, don't confuse spontaneous bacterial pleuritis to be exudative. It is still transudative only because it is the ascites fluid which has gone, which has got infected. Okay, so why? Because cell count was more and neutrophils was more. Culture was positive. We saw now initially culture positive greater than 250, culture negative greater than 500. We can call it to be spontaneous bacterial pleuritis. So these were the three main causes. One is nephrotic syndrome, which was our today's case. One is congestive cardiac failure. Second one is ascites. So this is how we approach a case of transudative fluid, transudative pleural effusion. Next, let's see exudative. So anything? Could you make spot diagnosis from this? Spot diagnosis. This is a CT scan, chest. Those arrows can help you. Just by looking, could anyone diagnose? Okay, now I'll start giving clues then. There is some amount of air collection in the mediastinum. Okay, this is the esophagus. This is the esophagus. Some amount of air collection is there. On inserting dye through the esophagus, that there is leakage of the dye, and this dye seeps through and comes into the place where there is pleural effusion. Yes, very good. It is esophageal rupture. And how do you confirm is on doing thoracocentesis, salivary amylase levels will be raised. Salivary amylase levels will be raised. That is how we confirm. Next, what is this? Anyone can diagnose this? Again, spot diagnosis. Anyone? Okay, now I'll start giving clue. Patient had acute pancreatitis a month back, following which, yes, it is a pseudocyst that has communicated into mediastinum and formed mediastinal cyst. And from here, there has been leakage, which has led to bilateral pleural effusion. Again, amylase levels are diagnostic, greater than 1500, I think. So amylase level greater than 1500 will be confirmatory, okay, for this case by doing thoracocentesis. So next we'll see two cases. We'll look into these two cases. Yeah, this is case 1, this is case 2, okay. So these are the chest X-ray. In first case, there is just unilateral small amount of pleural effusion. Sorry, in first case, there is bilateral, small pleural effusion, but bilateral. In the second case, there is large amount of pleural fluid collected, but it is unilateral, right-sided, okay. On doing thoracocentesis, this was there. Anyone can diagnose it? Okay. Bhavya is too quick. Second one is rheumatoid arthritis. Why do you say so, Bhavya? Very good. Glucose level less than 30 is almost diagnostic of this thing. Yeah. Rheumatoid arthritis. So we saw now whenever the glucose levels are less, we'll mainly think of malignancy, rheumatoid arthritis, tuberculosis, or a parapneumonic effusion. Okay. So that is how she got the diagnosis. And in that also, if it is less than 30, it is rheumatoid arthritis. Any other features to differentiate? What is the first case then? Both were a case of chronic low-grade continuous fever along with arthritis and all. First case is SLE. Very, very good. So till here, it is the same. It is a case of exudative. Next, when we see pleural fluid glucose is almost normal. Pleural fluid glucose is very less, and pH is normal, but pH is reduced in rheumatoid arthritis. So these are the differences. So we'll see what are the differences between SLE and rheumatoid arthritis. Most common manifestation in both is pleuritis with effusion, but in case of SLE, almost 40% there is incidence of pleural effusion. In rheumatoid arthritis, it's just 5%. Location, as we saw over here, bilateral small degree of effusion will be there. Okay, bilateral small degree of effusion will be there. But in rheumatoid arthritis, it will be unilateral, moderate to large grade effusion. Okay, on doing pleural fluid analysis, glucose, it is reduced. It is very much reduced, less than 30 grams per deciliter. But over here, it remains normal in case of SLE. pH is again reduced in case of rheumatoid arthritis, but over here, it almost usually remains normal. Okay, so these are important differentiating features from SLE and rheumatoid arthritis. So these are the two most common autoimmune conditions that can cause. Next, let's look into this case. Okay, patient presents with high-grade fever, cough, blood thin sputum. Okay, patient was started on empirical antibiotics, but again he came back on 5th day with no relief of symptoms, chest pain and dyspnea. So this is the same clinical scenario with two patients. Okay, first patient X-ray will be this, second patient X-ray is this, and this is thoracocentesis. This is what you found. Now anyone can make diagnosis. What is case 1? What is case 2? Okay, Bhavya, which is empyema? Case 1 is empyema or case 2 is empyema? Case 2 is empyema. Okay, why do you say so? Why is case 2 empyema? What is case 1 then? Again, you cannot tell empyema until and unless you do a thoracocentesis and see pus. Okay, so I have not mentioned pus over here. So you still cannot call it to be empyema, but okay, considered. Okay. It is case 1. It is a case of simple, uncomplicated parapneumonic effusion. Case 2, yeah, both are parapneumonic effusion. Case 1 is uncomplicated. Case 2 is complicated. Okay. So why it is said so? See, one, LDH levels are low, but over here LDH levels are high, greater than 1000. Next is culture and staining. It is negative, but this is positive for gram-positive cocci. Mostly it is Streptococcus pneumoniae is the most common cause. And pleural fluid glucose, it is almost normal. This is less. It is reduced. Again, pH is almost normal. It is very less. Okay. So we'll see how do we differentiate. So why do we differentiate is to if it is a complicated or if it is empyema-thoracis, we directly go drain. You put the ICD insertion and you do drainage. If it is simple, we wait for it to resolve. So how do we differentiate is important. This, in fact, is very important. Entrance exam or for your Viva, very important. Pleural fluid glucose. In complicated, it is great. Okay, I have put ulta. It is great. It is less than 40 grams per deciliter in complicated. In simple, it is greater. It will be almost normal. Next is pH. pH will be normal. pH will be reduced in case of complicated. Next is LDH. It will be usually less than 1000. In case of complicated, it will be more than 1000. Gram stain and culture will be positive. Over here, it is negative. And if you find any loculation or pleural thickening, again, it is complicated. You will tell it to be complicated. This is usually USG finding. Next, a complicated parapneumonic effusion on examination appearance, you'll find out pus. Then you call it as empyema-thoracis. So whether it is either empyema-thoracis or complicated, you directly do ICD insertion and drainage. That is why we classify. Okay. So let's look into this. A 65-year-old gentleman, he's been smoking since the past 30 years, comes with cough with scant sputum and dyspnea since the past 1 week. Left-sided pleural effusion was noted, as you see in this X-ray. Simple. Thoracocentesis revealed this. Appearance, red. Pleural fluid protein is raised. LDH is raised. WBCs, there is small amount of raise in WBCs with lymphocytosis. Culture negative, cytology negative. Pleural fluid glucose is 60. Okay. You cannot jump to malignancy directly. You will have to have a differential diagnosis in mind. With just this much cytology is negative, how can you tell it is malignancy? Okay, TB you tell, but what is acid fast stain is still negative. How can you tell it is TB? Malignancy and TB you guys are considering, okay. And when it is still undiagnostic, what is the one more thing that you'll have to consider? He is smoking. So he is again prone to what? Pulmonary embolism. Okay, very good. So it can be any of the three. He is old age plus a smoker, prone to malignancy and pulmonary embolism. Old age itself is prone to TB. So anything can be present. So, and thoracocentesis, by looking at thoracocentesis, any of the three can be present. Correct, no? So in such conditions, what do we do next? What do we do next? Till now, it was well and easy. Thoracocentesis you do, look at the imaging, you could have diagnosed easily. But now what do you do? Okay, before doing invasive procedure, why do you directly want to go do invasive procedure? If you could have ruled out pulmonary embolism as the cause, then there is no need to do an invasive procedure. Yes, first you do CT angio. In all such cases, a case of nephrotic syndrome, a case of CCF, and when it is not, when we are not able to diagnose, we go ahead and do CT angiography. If CT angiography get an embolus, well and good. It is diagnostic of it. So, and what are the other features in case of pulmonary embolism? Red color fluid will be there, exudative in nature, increased RBCs can be present, increased WBCs can be present, and on doing DLC, either neutrophils can be raised, or lymphocytes can be raised, or eosinophilia can be there. So any of them can be there. Best test is CTPA. Okay. In this patient, we ruled out CTPA, turned out to be negative. There was no embolus. Next, what do we do? What is the next thing we do? Now we have only two things in our mind: malignancy and TB. These are the only two things in our head. Yes, biopsy. If you're considering TB, what biopsy you will do? If you're considering malignancy, what your biopsy you will do? Okay, Bhavya is telling gene expert. Gene expert we could have done with pleural fluid analysis itself. That also turned to be negative. Bhavya. VATS in TB. No, in needle guided, direct needle guided biopsy can be done in TB. It gives a good yield. Malignancy, we do an invasive procedure. Okay, so TB, once it is not diagnostic, once the pleural fluid analysis is not diagnostic, we can go ahead and do pleural fluid markers, okay, like ADA, interferon gamma, or gene expert, all those things you can do. But the gold standard is biopsy of the pleura. But we don't need an image guided. Direct biopsy also yields. We can get a good yield by doing direct pleural fluid biopsy only. But in case of malignancy, we should always consider an invasive procedure. That is the best, either CT guided or video assisted thoracoscopy. And next, there are two entities. One is chylothorax. Chylothorax is nothing but thoracic duct is disrupted and chyle enters the thorax. So it can be either because of trauma or a mediastinal tumor. So what is pseudochylothorax? How do you differentiate it? Over here, there is cholesterol-rich fluid. It is not the chyle that enters, but it is cholesterol-rich fluid. So one over here causes TB or rheumatoid arthritis, rheumatoid arthritis leading to pleuritis. Okay. So how do we differentiate? One is based on appearance. It is milky. Over here also it is milky, but on doing microscopy, you'll find cholesterol crystals. Triglyceride levels will be more, it will be less. Cholesterol will be less, cholesterol will be more because it is cholesterol-rich fluid that has been accumulated. By history itself, you'll get to know because this is an acute process and chronic process. And the best one is to do chylomicrons. Chylomicrons will be positive because it is chyle. And this is just cholesterol-rich fluid. You will not be able to find any chylomicrons. Finally, hemothorax. It is blood in pleural fluid, but how do you confirm? By doing hematocrit. Hematocrit, when it is more than 1/2 of the peripheral blood, only then you think of hemothorax. It can be due to trauma, dissection, blunt trauma, all those things. Okay, treatment, tube thoracostomy, invariably you'll have to do. If it is greater than 200 ml per hour fluid drainage, then you go into thoracoscopy or thoracotomy. Okay, so finally we'll end the class. So what was it? How do we diagnose? Good history. Okay, good history. Do examination. You confirm using a radiography. After that, do the diagnostic thoracocentesis. Apply Light's criteria. See whether it's exudative or transudate. Transudate is okay, easy to diagnose. Congestive heart failure, cirrhosis, or nephrotic syndrome. In these two conditions, always go ahead and do a CT scan. Don't forget. If it is exudate, then do the basic investigations, pleural fluid analysis. Okay, these are the basic investigations. If glucose is low, as told, you can think of this: malignancy, rheumatoid arthritis, bacterial infection, either pneumonic or a TB. Still no diagnosis, do CT pulmonary angiography, rule out pulmonary embolism. Still no, then you will look for pleural fluid markers, as we saw, like ADA, interferon gamma, all those things. Rule out TB. Still no, if symptoms are improving, we just observe the patient. If the patient is still anxious, he wants to know the diagnosis, LDS levels are increasing, symptoms are worsening, then what we do? We do invasive procedure, image guided biopsy or a blind biopsy for tuberculosis. Okay, so that's it. Okay, very long case that was. Very sorry, since we dealt with that examination part in detail about our first case, it went off for a long time. So I had thought to split the class into two. So I went detail with the case. I'm surprised that many of you stayed. Okay, there were around 25 people who stayed. Thank you very much for listening. Any doubts? Yeah, welcome. Any doubts regarding this? Sent to you. Okay, fine. Then let's end the class. Thank you, guys.